Hi, good evening, everyone. We'll start in just 1 minute. Uh, so, yeah. So, Dr. Silima, are you ready? Ready to go live?
Yes, sir.
Yeah. Okay.
Yeah.
Thank you. So, good evening, everyone, and thank you all for joining us for the third part of our year-end review, YEARMED 2024. And thank you to Dr. Silima for accepting our invitation to be a part of this. The first part was on endocrinology. The second part was on obesity and metabolism. And the third part is the most awaited of all, that is the review of the articles published in 2024 in the field of diabetes. So with me today is Dr. Silima. Dr. Silima Tarenia, she has done entire medical education from Kolkata. So she's done her MD internal medicine from Kolkata. She has done a DM endocrinology and DRNB endocrinology, which she finished in 2021, her DM, and 2022, her DRNB endocrinology. And she's always been interested, as I understand, in the field of endocrinology and diabetes. So both her MD thesis and DM thesis were in the fields of diabetes. So her MD thesis was on GGT in first degree relatives of patients with type 2 diabetes. And then her DM thesis was on idiopathic type 1 diabetes. A brilliant student across her academic career and a brilliant endocrinologist. And she's currently working as a visiting consultant at Medica Super Specialty Hospital and also at Tata Memorial Center. So welcome, Dr. Silima, to our session, and thank you for joining us.
Thank you, sir. Thank you for the kind invitation. And
Thank
sir,
you so
I would
much.
like to not only just thank you for this invitation for this session, but also a big thank you for choosing and precisely selecting these interesting topics and then carefully and precisely curating them at this platform. Indeed, I learned a lot while going through, got a lot of new ideas and learned a lot of new things. So thanks again for that.
Thank you, Dr. Silima. So, once again, good evening to all of you. And what we're going to do, as you're well aware, is that we are going to present a series of interesting articles published in 2024. Most of the articles that we've chosen are the articles which are practically relevant, which are useful in clinical practice. And I'll present the article and then we'll have a round of discussion with Dr. Silima. And again, some housekeeping rules. So if you have any questions, please feel free to ask them in the chat box. So we'll be taking the question along with our discussion as well. So, whenever if a question pops up in your mind while the presentation is going on, please feel free to add them. We're also having a series of poll questions also. So please participate in the poll question so that it becomes more interactive. So I'll start by presenting my slides. Yeah, so are my slides visible? Is the slide visible?
Yes, sir.
Yeah, okay, thank you. So we are in the third part of, and the third and the last part of YEARMED series, the year in review with diabetes. Now, again, those who have done this before are aware that you can go to technocrinology.com, that's the site, and just sign up for the YEARMED. And here you will be able to take all the, whatever we are discussing, you'll be able to look at the detailed summaries of all the papers we are discussing, along with the citations, some additional topic notes as well. Interactive polls also we have on the same, and then there'll be some useful mini application and toolboxes there. And in the end today, you'll be able to download a certificate of participation also right from the technocrinology.com website. So I'll encourage you to just go to technocrinology.com, sign up. Again, the previous sessions of the YEARMED, that is the part 1 and part 2, also will be there, and the video recordings of the same will be there. And this one we are discussing today will also be live streamed on our Endocrinology India YouTube channel, as well as it will be available after the session on this platform as well. So you'll be able to review this in case you missed something useful. Okay, so let's start with the first topic, and we'll be revisiting the topic of metformin. And let me just launch a poll question for you. So this is a little poll we are asking that, do you still use metformin alone in clinical practice? Do you still use plain metformin in your practice? The options are yes, rarely, no, I generally use it in combination with other drugs, and no, I don't use much of metformin at all in my practice. So please enter your poll questions. While we discuss this, we'll be discussing the results of the poll also in a few minutes. Okay. So moving on to the topic of metformin, and you'll be wondering that in a year-end review of 2024, we are still talking about metformin, but there are some very interesting articles related to metformin published in 2024, all of them relevant to clinical practice. So this is the article which was published by Kong Zi et al. And they talked about timing of metformin administration. So what they said was that the impact of metformin. So when do you give metformin, before meal, after meal? It does impact the response of the patient in terms of metformin. And also, very interestingly, and we have suspected this for a long, long time, that metformin is linked with GLP-1 receptor with release of GLP-1. And in this study, it was actually proven. So this was actually an experimental study. There was an experiment. This was a double-blind, placebo-controlled crossover design experiment in 16 participants. So what they did was they had early administration of metformin about 60 minutes and 30 minutes before giving glucose. And then they gave a glucose infusion to these 16 participants after giving the metformin. And what they found was that if metformin was given before meal, it leads to increase of the GLP-1 level in these participants, right? So actually they did the intraduodenal measurement of GLP-1. And there was, of course, no significant difference in insulin sensitivity, but metformin did increase insulin levels postprandially. But very interestingly, the GLP-1 release was more prominent when metformin was given before the meal. So what they found was that administering metformin 30 to 60 minutes before meal may actually enhance its postprandial effect in terms of augmenting the GLP-1 response and potentially optimizing the diabetes management. So let me give you more details of how the study was done. So basically, the idea was to see whether metformin administration has an impact on the GLP-1 levels in these participants. So they take 16 patients with generally well-controlled type 2 diabetes on metformin. And on 4 separate days, each of the participants received 1 gram of metformin or placebo saline directly injected into the small intestine via a tube, 60 minutes before glucose and 30 minutes before glucose at the same time of glucose, or in the control group, just the saline was given. And this was followed by intraduodenal glucose infusion, which was basically mimicking a meal. And then after that, they measured the blood glucose, insulin level, the GLP-1 levels over 2 hours after the glucose infusion. And what they found was that metformin worked better to lower the glucose and increase GLP levels when given 30 to 60 minutes before the glucose was given. And again, in terms of side effects, there was no significant difference in side effects. So overall, what they concluded was that taking metformin 30 to 60 in an experimental trial, they actually found that metformin 30 to 60 minutes before meal may actually have efficacy in the glucose lowering effect of metformin. And mainly, this effect is driven via GLP-1 secretion. Now, there's another paper which in the same line. So, I added this here. And this is a paper on metformin and the GI tract. So it's a review article basically looking at how metformin works on the GI tract. Again, this was published by Cheng M et al. In the Frontiers of Clinical Pharmacology about understanding the mechanism of metformin in the GI tract. And basically the idea was how, they wanted to explore how, in terms of a review, how metformin basically affects the gastrointestinal tract. Now they found different mechanisms, right? So there were 6 different mechanisms they found in terms of overall efficacy. So basically, what they found was that there's a lot of recent evidence to suggest that the GI is one of the primary sites for metformin action, right? We all know this, a lot of our patients complain about GI side effects in terms of metformin, but it also works, we always thought that metformin is basically reduces the primary action of metformin was thought to reduce the central insulin resistance, that is the liver glucose production. But what now, we are increasingly discovering that it also works through the gastrointestinal tract. Now, metformin basically reduces glucose absorption in the intestine by modulating the SGLT1. Remember, SGLT2 you have in the kidneys, you have SGLT1 in the intestine, and this SGLT1 and the GLUT2 is modulated by metformin. So metformin has a SGLT1 inhibition, and this enhances basically reduces the glucose uptake from the intestine and enhances its removal from the GI tract into the fecus. And as far as the hormonal effects are concerned, we already saw that metformin actually stimulates the GLP-1 release, which promotes the insulin secretion and reduces glucagon level. And also, it has direct actions, but it has some indirect action in terms of changing the gut microbiota also. So this also may have a little bit of effect. Of course, the same thing also leads to the side effects of metformin. That is, it leads to nausea, diarrhea, bloating. Also, this could be because of the change in the gut microbiota and the drug transporter proteins. Again, another common side effect is B12 deficiency, which is also because of the same interesting action. So point here is, and what's the important take-home message is that metformin, we all know this, but this is now reiterated by this review article that metformin basically, has action through the GI tract, right? So we ran this poll question, and we'll take the questions with Dr. Silima. And the poll question we asked our participants that do you still use metformin alone in clinical practice? And 78% of the participants still continue to use metformin alone as a primary drug in their clinical practice. So Dr. Silima, let me ask you this. Do you have patients of yours on metformin alone still in practice?
Yes, sir. I do have a certain subset of patients, particularly maybe say newly diagnosed, yeah, on the younger side, say a male patient
Mhm.
comes who's overweight or maybe towards the side of obesity, and the sugars are not really very, very high. So
Right.
along with dietary modifications, lifestyle management, if we maybe start with a low dose, maybe a moderate dose of metformin, I
Mhm.
have seen that it works wonders. So
Right.
metformin still has its place as an individual agent. Of course, it can be combined and it's convenient to combine it with other agents. But as a single agent also, I'm sure there are a subset of patients who would be benefited from metformin alone in the management of diabetes.
So up to what HbA1c would you use metformin alone in your practice? So a newly diagnosed patient comes to you,
Maybe
hmm, yeah,
so maybe 7 to 7.5, but
okay,
probably beyond that, I would be wanting another option along with it.
right, okay. And if you do choose a second option, let's say a patient has an HbA1c of let's say 8%, what's your generally preferred second line drug along with metformin in
So, sir,
combination?
here there are a lot of factors. Yes, there
Hmm,
are a lot of factors involved. For instance, if the patient is having any kind of a ACVT risk factor, or there's
hmm,
a family history of hypertension, stroke, or the patient is obese, smoker. So, in that case, maybe I would definitely try to opt for an SGLT2 inhibitor. And but otherwise, sir, if nothing is there and the sugars are on the higher side, the HbA1c is on the higher side, and I'm not opting for insulin, with metformin, usually my second choice is a sulfonylurea.
okay,
Because I've seen these two drugs together, they are really potent in bringing down the blood sugar levels. But yes, of course, SGLT2 inhibitors or the GLP-1 analogs, they
hmm,
score over where there is the additional advantages of organ protection and CVT benefits, etc. So that's
yeah.
one issue.
Yeah, fair enough. Great. So, Dr. Silima, you saw this article, very interesting article, right? So you
Yes.
had, they experimentally did this study where they looked at giving metformin before meal, 30 minutes, 60 minutes, or along with the glucose. So in your practice, how do you really administer metformin? Do you give it before meals? Do you give it along with the meal? Do you give it after meal? What's your general usual take for your patients just on metformin?
So, sir, usually I time the metformin depending upon the side effect profile rather than the topic that we just discussed, that
Right.
metformin administered previously is having a host of beneficial effects in terms of GLP-1, etc. So, that is the glycemic efficacy. But I am usually a little bit skeptic regarding the side effects in terms of nausea,
Right.
vomiting, or whatever it may be, because at least 20 to 30% of my patients do come to me with this problem
Right.
of
Right.
metformin intolerance. So that is one of the reasons why I usually prefer to administer it after a meal. But then again, considering the efficacy now, if there would be patients who would be adjusting it easily, maybe I
Mhm.
would be preferring to administer it before the meals.
Yeah, very interesting. So, and do you change your preference based on whether it's a plain metformin or whether it's a sustained release or a extended release metformin? Does that
Yes, sir,
influence your decision? Yeah,
yes, sir. Like if it's an extended release combination, so in that case, the patient is going to have lesser amount of side effects, and if
right,
it's combined with another drug, then again, it's individualized depending
right,
upon the
right.
situation.
Depending on the GI side effects of the patient and
Yes,
GI
yes,
tolerance of the patient, right?
yes.
Great. So I think that's a great. So it's an interesting point. That it does increase GLP when it's given before the meal, but however, very rightly said that the GI side effects also increase when it is given in the same way. Probably it's a link there, Dr. Silima, don't you think? Because you have more GLP being released, probably you
Yes.
also have more side
Yes,
effects.
probably it's the gut axis or the relation, which I'm sure
Which
more and more newer data is coming up that way. So, but there must be, I assume.
there must be a relation there, right? Very interesting. Okay, and for some of your patients, who do experience GI side effects, what do you do? Do you discontinue metformin completely, or how? Obviously it will be case by case basis, but in general, what's your approach to patients who do complain of the GI side effects after starting metformin?
So, sir, in general, if a patient is coming whom I have already administered metformin and the patient is complaining of GI side effects,
Hmm.
so maybe I would down titrate it again. start with a lower dose just to give it another trial that maybe a lesser dose would be suitable, and then we can just very slowly titrate. Another option would be to go for an opt for an extended release combination. And most of the times, the option of giving it after the meal, I usually follow it right from the beginning. So there, I do not have much scope of exploration. And another issue is, sir, in some of the cases, maybe some of the cases do respond well, and these patients, after down titrating at starting it slowly, increasing the dose, it suits them. But there are a few subset of patients, no matter what we do, they absolutely cannot tolerate metformin. So those
Right.
patients only, I would opt for an alternate medication. Otherwise, I do try my best so that we can continue metformin.
Great, great point. Okay, and we have this often the debate of now of course your new drug has come into market, which is called Imigliamine, right? And
Imigliamine, yes.
one of the pitch of this drug is that it has lesser GI side effects at the same time maintaining the benefits of metformin. So there's a question from Dr. Parag Agrawal, who has specifically asked this, that some of the GI benefits of metformin that we saw in the review article, does that also extend to Imigliamine? And what's in general, what's your view on Imigliamine so far from whatever you used?
So, sir, I do have a limited experience of using Imigliamine, and
Hmm.
usually it is not one of my first options. But
Right.
then I must agree that if there is a patient who's on a sulfonylurea, DPP-4, metformin, and maybe another drug, and is refusing insulin, but the sugars are not controlled, I would add Imigliamine there. And another option is, like you just mentioned, patients who are having metformin intolerance. In fact, me and this is Dr. Shambho, sir. I think you
Hmm.
probably know him. We're
Yeah,
trying to
yeah.
conduct a study on this, that those patients who are on metformin and then intolerance, and then we're switching on to Imigliamine. So
Mhm.
what would be the outcome? So we have to just wait for that. But sir,
Okay.
in the limited practice that I have seen some patients who have yielded good results in terms of HbA1c control was fine, and they didn't have the side effects to the tune of what they had with metformin.
Right. Okay. So it's an interesting area in terms of development, and I think we are just we are very rightly said that it's still we are still experiencing this drug. So I think it's too early really to say what really comes out of it. Very interesting point. I'll just give you one view of thing which I learned over a period of time. This was taught to me by my teachers. That if you want to plain metformin, like Dr. Silima very rightly said, has more GI issues, but which can be actually helpful for weight loss. So, this is what was taught to us, that, obese younger patients, this is before the era of now, SGLT2s and GLP-1 receptor agonists, which, of course they were there, but they're not that popular at that time and very expensive. We are taught that, if you want your patients to lose weight, give them a plain metformin and give it before meal. And, though they will have GI side effects, they'll actually lose a little bit of weight, the appetite suppression, and that will be better. And that is what was taught to us. So we actually use that in our practice also, as a resident. But I think, side effects for some may be beneficial for others, as we saw from the research with GLP-1, which was actually intended to be anti-diabetic drugs, which, one of the side effects then became the primary reason why it was being used in practice. Dr. Nazir has asked this, Dr. Silima, would, somebody with a low BMI, would you consider metformin as a sort of a relative contraindication, or would you prefer metformin less in a patient with a low BMI and, diabetes? So this typical Indian thin, lean diabetic patients, would metformin go lower in your preference?
So actually, there are a lot of parameters here, I would say, because whenever the question of lean thin is coming, it's just as per the BMI. But actually,
Right.
the visceral fat needs to be considered. And in Indian populations, we know that visceral fat, which is another issue that has got to deal with insulin resistance. And we know that
Correct.
metformin has a role with insulin resistance. And per se, sir, metformin doesn't really cause a significant weight loss. In
Correct.
fact, in many
Correct.
situations, it can be weight neutral also,
Right.
and maybe some degree of weight loss, which is not very huge as to affect the patient. Because when
Correct.
what we see with the GLP-1s or even with the SGLT2 analogs, sometimes we do get patients who are coming to us and saying, we are losing so much of weight. Is there any medicine which is responsible for this? And we might have to stop it also. But
Right.
for metformin, I personally haven't really faced something. So even for a lean thin individual, I would not reject off metformin just because the patient is lean. Maybe
Right.
if there would be a high creatinine or something else, that's a different thing, or a severe GI intolerance. But just by becoming lean, that would not be a parameter for me to not prescribe metformin.
Yeah, completely agree. So I think it's a great point, and you're very right. A lot of patients actually are on SGLT2 and come to you complaining about weight loss, and then you look at the prescription and you clearly find that there was an SGLT2 to cause. Now let's look at some of the updates in the field of diabetic kidney disease. This was a year where diabetic kidney disease, in fact, in the last few years, there are two organs which are in a lot of limelight. One is the kidney and other is the liver, right? The era of heart medicines is now slightly out. You're now more of the liver and kidney being discussed. So there was this flow trial, which was the effect of semaglutide on chronic kidney disease. This was published in New England Journal of Medicine. Just to say a one-line summary, the study evaluated the impact of semaglutide in kidney outcomes in patients with type 2 diabetes and chronic kidney disease. This is very similar to the EMPA-REC trials and the other, EMPA-CKD and the other, DEPA-CKD trials, all the SGLT2 trials. So they're a very similar trial in that sense. There are about 3,000 patients with type 2 diabetes with the CKD who were included in this patient. And just like the other earlier trials, they looked at the patients, the decline in the renal function. They looked at the cardiovascular outcomes also, and that's the overall package they looked at. And what they found was that semaglutide not only reduces the progression of chronic kidney disease in type 2 diabetes, but also significantly lowers the risk of cardiovascular events and mortality, and makes it a very useful value addition for patients with chronic kidney disease. So I think it's a very interesting and important trial in that regards. But not only that, as far as the chronic kidney disease is concerned, there's also very interesting KDIGO guideline updates on CKD. Some of the important areas which are relevant to our practice in terms of diabetes and endocrinology is that they included both SGLT2 and GLP-1 receptor agonists as important drugs for slowing the progression of chronic kidney disease. They also emphasized on use of urine albumin-creatinine ratio as an early test for detecting CKD. But also one thing very important, and which is, I think, all of you listening to this must be keeping in mind, a doubling of urine albumin-creatinine ratio of more than 20 or decline of more than 20% in EGFR should prompt evaluation of a patient, right? So whenever you have, let's say, a patient has urine albumin-creatinine ratio of 300, and on follow-up comes with 600, there's a doubling of UACR. Or if the EGFR falls by more than 20% over a period of time, you should look at some sort of risk factor and look at the patient more closely. They also developed some risk prediction models for the CKD patients. This is there in the KDIGO guidelines, so you can go through that in more detail. They also talked about cystatin C, which is making a small comeback these days. What they're saying is that serum creatinine and cystatin C both can be used for calculating EGFR. And in fact, patients with muscle wasting and severe illness, probably cystatin C could be a useful marker in terms of the CKD progression. And they also, of course, talked about redefining CKD progression. So CKD progression, earlier there used to be some definitions for CKD progression. Now they're saying that progression is now defined as any clinical significant decline in EGFR or albuminuria that exceeds the expected variability. So now they made it very open. So there are no fixed thresholds right now, and they kind of made it like an open area for CKD progression. And very importantly, this is one thing which I think is very important. They talked about treatments like SGLT2 inhibitors or NS-mRNA, which is NSMRAs, which are basically Findrinone or non-steroidal mineralocorticoid receptor antagonist. When there is a transient drop of EGFR more than 30%, the drug should not be stopped. That is a very, very important area. I think very important practical point. So what used to happen is, what typically happens in clinical practice is that when you have a patient with CKD and you start the patient on an SGLT2 inhibitor or you start the patient on Findrinone, there is an initial decline of EGFR or there's increase of creatinine. And this initial decline often spooks the patient and the doctor also. And sometimes they stop this drug, which should not be done. That is what the current guideline says, that, up to, there could be a transient 30% drop in the EGFR, and that should not lead to discontinuation of your medication. So we have actually asked the same question as a poll question. 62-year-old male patient with type 2 diabetes, hypertension, and CKD3B with the eGFR of 35 is started on empagliflozin. His medications include lisinopril, metformin, and amlodipine. At a 2-week follow-up visit, his eGFR decreased to 24. There was a 31% reduction. He's asymptomatic with stable blood pressure and no signs of volume depletion. What is the most appropriate step for this patient? So this is the MCQ question we have asked. Should you immediately discontinue empagliflozin? Should you continue empagliflozin with a close monitoring and reassess in 2 to 4 weeks? Should you discontinue both empa and lisinopril, or should you switch empagliflozin to another diabetes medication? So this is the question we have asked, and I'm very happy to see that most of you have actually answered as per the guideline recommendation. So let's take this question with Dr. Silima. And Dr. Silima, in your practice, you would have seen patients with CKD, and sometimes, when you give them an SGLT2 inhibitor or give them a Finrenon, there is a transient, drop of EGFR or increase of creatinine. So, what do you do? Of course, the guideline now is very clear of what is to be done. But what are your views on in clinical practice regarding this?
So in the clinical practice, of course, because initially it is expected that there'll be a small little decline. So I think
Right.
counseling the patient is very important, that up to
Yeah.
20% or so is there. We're just going to closely follow up and monitor, because we don't really know what's going to happen. So
Correct.
after, say, about 6 weeks to 12 weeks, if the patient comes back, and then we see that it's a plateau, so we need not worry about. But if it's constantly going down, then that's a different issue, and that needs
Yeah.
to be taken care of.
Yeah. So very, very true. So I'll give you some practical pointers here. A couple of things. So again, to the dear audience, what happens is that those people who actually have this transient decline of EGFR actually have good long-term results. So this is what studies have also shown, that some of these patients where there is this little drop of the EGFR or little increase of creatinine after starting all of these medications, they could sometimes over a period of time actually do well in terms of overall outcome. And also, what is very interesting, and it's a practical pointer, now, if you give ACE inhibitor, let's say you take a patient not on any of these medication, you start them on ACE inhibitor ARB, plus also SGLT2, plus also Finrenon. If you give multiple drugs, there is almost very good chances that the creatinine will increase. So what we have learned, again, sometimes the hard way, is that though the guidelines are very clear that you add everything right at the go, in clinical practice, we often do it serially. So we often, would add an ACE inhibitor or ARB first. Then on, maybe a couple of weeks follow-up, you add a SGLT2, and then a couple of weeks follow-up, maybe add a Finrenon or whatever, additional drug that you require. Because, you don't want that in the very next visit, patient going to a nephrologist and the nephrologist stopping all these drugs. That is also common, another common issue that often arises. So I think, these are some practical issues that we need to be aware. And one thing I'll tell you, the glomerular changes that you experience, these are all mainly because of the changes in the glomerular filtration, which leads to the changes in EGFR. These are all transient and these are all reversible. What is damaging is the acute tubular necrosis. So if you have a patient with an ATN where you have tubular damage, that is permanent and that can lead to problems. So if you have a patient who is dehydrated, like, in this case scenario, they clearly said the patient is asymptomatic and not dehydrated. If you have a dehydrated patient, if you have a patient with significant volume loss, then you need to stop this medication, because that will otherwise lead to an ATN, which can be potentially dangerous. So Dr. Silima, you in your practice, you see a lot of this diabetic patients with elevated urine albumin-creatinine ratio. What's your general, approach to such patients in terms of clinical practice?
Yes, so sir, this is a very common scenario that we encounter in our daily practice, a diabetic patient coming with a raised ACR. Now, this can be asymptomatic or symptomatic. Some of them complain of frothy urine. Can be either microalbuminuria or macro, depending upon the degree, whether it's less than 300 or greater than that. So first and most important is we need to ensure that the procedure has been done correctly or not. That is the point when the ACR was done. The patient was not having any UTI, there was no fever, there was no active exercise, etc. And most importantly, the glycemic control is very important. Because if the sugars are on the higher side, then it's going to give us a falsely high urine ACR and we would be misguided. So in that situation, what we do is we repeat it after, say, about 6 to 8 weeks. And once the confounding factors are also clear and we're sure that is definitely there's a high degree of urine ACR. So first and foremost, we need to run a few extra tests like the creatinine and the sodium potassium to look at the overall status of the kidney, and also a retinopathy, because there is 60% concordance with a diabetic kidney disease and retinopathy. Beyond this, when we start treatment, it's not directly the drugs. Diet, exercise, the lifestyle modification is very important. Obesity management, because overweight, obesity also adds on to the proteinuria. After that, when we start with the drugs, like you were just mentioning, we should go sequentially. So we have to start with a AC inhibitor or a ARB, and then we need to gradually up titrate it to the highest possible dose. In some cases, depending upon the degree of proteinuria, we might as well add an SGLT2I from the beginning, or we can just add later on. Now, all these drugs, usually they take at least 6 to 8 weeks minimum to bring down the ACR levels, and the expected benefit would be less than 30. But if we do not reach the target, then we can try a Finrenon also. But then again, the potassium also has to be kept in check. So I would say this is how.
Yeah. Okay. So great points here. And Dr. Silima, in the light of the same thing, we of course you already mentioned this. In your opinion, now this is this pillars of treatment, right? In heart failure, they already have
Yes.
4 pillars of heart failure. What are your 4 pillars of diabetic kidney disease in current era? Let's forget
Okay,
the
sir. So
practical aspects and just from a scientific perspective, 4 essential drugs you'll give to any of your patients with diabetic kidney disease.
yes, sir. So, of course, like you said, diet lifestyle goes hand in hand.
Right.
So, to start
Right.
with, there are so many new drugs which have come up in these last few years, and trials have shown that they are having renal benefits. So, an SGLT2I would definitely be a choice.
Sure.
And especially, sir, like this DAPA and EMPA up to a EGFR of around 20 to 25, we can give them. But then the glycemic benefits might stop, but the renal benefits continue even
Correct.
if the GFR drops below that. So ARB again is a drug which is going to take care of the cardiac effects. So that is one medicine we need to give, but then again, we have to be very careful about the creatinine. Second is the GLP-1 analogs, which recently are showing a lot of benefits. And fourth would be maybe Finerenone. That
Right.
again is
Right.
another
Yeah.
drug which is new in the armamentarium. So I think these 4.
Yeah, absolutely. And Dr. Silima, the float trial did make a lot of noise this year.
Yes.
So what are your views on this trial specifically?
So yes,
Yeah.
so actually, sir, this basically, even though we are having a lot of existing established drugs for the prevention of progression of diabetic kidney disease, but still there is a vast amount of risk factors there. And like the previous trials have indeed shown that GLP-1 analogs do have a beneficial effect on the progression, but all of these data were indirect evidence because that was from CVOT. So this was the first trial where they have actually taken, it's a renal dedicated trial. They have taken kidney patients, diabetic patients who are having kidney disease and who are on the higher side of worsening or progressing. So that way I would say, and of course, they have shown benefits like you just mentioned in terms of primary and secondary endpoints. So I must say that the advantages would be there were a lot of patients involved and they have done it thoroughly. So that does give us an impetus regarding the potential benefits. But then few limitations which I feel is that when this trial was done, SGLT2 inhibitors and Finerenone, etc., they have been used at very modest doses. So we don't really know whether together what would have been the exact effect. And I feel the young uh, diabetic, non-obese diabetic probably haven't been shown in a greater light that what would have been the effect of semaglutide in these patients. And lastly, sir, another issue is India being a country which is second largest in terms of diabetes. There was only 6% representation. So maybe if we would have some Indian data in this regard, it would be much more helpful for us in deciding. Otherwise, it's got a lot of positive data which can be extrapolated in the practical scenario.
Great points. Great points. So I think, we have a couple of questions from the audience, and Dr. Nazir is asking about metformin and GTM. We'll discuss specifically this point. We are going to talk about this in a few minutes. And Abhijit is asking, when will semaglutide be launched? Well, semaglutide, you already have oral semaglutide in India, and the injectable one is likely to be launched next year in 2025. Yeah. So that's answer to these questions. Let's move on to another interesting topic, and that is diabetes in pregnancy. And there are very interesting papers this year for diabetes in pregnancy. And let me launch a little poll for you in this regard. So this is again a clinical scenario which you have put. So we have a 31-year-old woman with type 2 diabetes, presents at 6 weeks gestation, confirmed by ultrasound. She has been well controlled on metformin, about 1 gram twice a day, with HbA1c of 6.4 for the past year. And she has no complications of diabetes. During her pre-pregnancy counseling, she was advised that she might need to switch to insulin during pregnancy, and she's now seeking your guidance on the current evidence. So she's already on metformin, her HbA1c is 6.4, she's doing reasonably fine. What would you do? So would you switch this patient immediately and discontinue metformin and switch to insulin only, as this is the safest for fetus? Would you continue metformin and add insulin as needed, given the evidence? There's now emerging evidence, so we'll discuss that. Would you stop all diabetes medication and just monitor on diet and exercise, or would you switch to an alternative oral diabetic medication that has more safety in terms of pregnancy? So please answer this poll while we discuss this, a couple of, scenarios with regard to diabetes in pregnancy. There's this, let's start with this paper on early GDM detection. So this is a paper from India. So this is a review article, meta-analysis, which is being done. systemic review and meta-analysis by Dr. Saptarishi and Dr. Lakshmi Nakendra, who was the faculty in the first part of a meeting today. So what they looked was the early GDM. They looked at the first trimester fasting plasma glucose as a predictor of subsequent gestational diabetes and the overall feto-maternal outcome. So that was the whole idea. And what they found was that women who developed GDM at 24 to 28 weeks had significantly higher first trimester fasting plasma glucose than those who did not. In simple terms, those patients with fasting plasma glucose of more than 91.8 milligram per deciliter was associated with higher risk of GDM, preeclampsia, gestational hypertension, large for gestational age. And those with more than 108 predicted to have macrosomia, again, large for gestational age and preterm delivery, but did not correlate with small for gestational age and LSES. So the point is that higher, especially if your fasting plasma glucose in first trimester is more than 91.8, these women are more likely to develop gestational diabetes and also more likely to develop complications associated with this. So this is a meta-analysis done with 16 trials in more than about 1 lakh pregnancies. And they basically looked at the first trimester fasting plasma glucose. So the practical take-home message here is that a first trimester of FPG can be a valuable predictor of gestational diabetes and other adverse outcomes. So again, if you have a patient with this type of clinical picture, it would be a good idea to really look at them very closely because they are more likely to develop gestational diabetes, and also look at doing some sort of a lifestyle intervention early on in the pregnancy so that they do not develop the diabetes related complication. The second article, which is again published in Annals of Internal Medicine, again, very interesting paper. And this is, I think, very important from a practical perspective. So they looked at metformin use in first trimester of pregnancy and the risk of non-live births and congenital malformations. And they emulated a target trial using real world data. Okay, so this is a real world study. This is not a clinical trial, it's a real world data. Right, so they looked at the US Medicaid Healthcare Administration data from last 18 years, so 2000 to 2018, so 18-year data. They focused on pregnant women with pre-existing type 2 diabetes, and they took that patients who compared the patients who were continuing metformin and versus patients who had stopped metformin and switched to just insulin alone. So that is what they looked at, in that outcomes, and they looked at the risk for non-live births, that is fetal loss, along with the other parameters as well. Looked at congenital malformations and again other factors. So what they found was the risk for non-live births was slightly higher in metformin plus insulin group, but it was statistically insignificant. So there was a slight increased risk, but probably there was not significant. And again, there is a risk of congenital malformation was actually lower in metformin plus insulin group compared to insulin alone. And of course, they looked at there could be potential confounding. Remember, this is a retrospective study. This is not a prospective clinical trial. So again, there could be a lot of confounding bias also involved in this clinical practice. But overall, the conclusion from this study, which a large number of data which was collected, they found that pregnant women with type 2 diabetes continuing metformin in addition to insulin in the first trimester may not increase the risk of non-live births or congenital malformation, significantly challenging the existing guidelines that recommend switching to insulin alone. So there is no need to just, you can actually continue continue metformin in such patients. So metformin versus insulin or metformin continuing is a very contentious issue. But I think this is one study published in 2024 does tell you that there is some safety in terms of continuing metformin, at least from a retrospective data perspective. Okay, and then there's another study which looked at a very interesting biomarker, which is CD59, glycated CD59. So they found that glycated CD59 may be a very good, this was published in one of the Nature journals, glycated CD15 may actually be a very good clinical marker for, gestational diabetes. So basically, they found that glycated CD59 was significantly higher in GDM patients compared to those who had normal glucose tolerance. And again, the area of curve was, diagnostic GDM was having reasonably good sensitivity and specificity of taking, the glycated CD59. And when glycated CD59 was combined with fasting glucose, it actually improved the diagnostic yield also to close to area under the curve of 0.871, which is pretty good. So what they originally said was that the glycated CD59 may be a very interesting and important marker for use in clinical practice in future for predicting for diagnosing gestational diabetes. So I think this makes it a very interesting. This is just again a very early point. So maybe in future, we'll be getting more clarity about this new biomarker which is emerging. Okay, so this is something you can watch out for in terms of the future. So let's now go to Dr. Silima. And Dr. Silima, let's start with the more contentious question, right, which was the topic of metformin in pregnancy. right? So this, clinical vignette which we put. So you have, let's say this is your patient. Your patient is already on metformin, HbA1c 6.5, 6.4. She's doing fine. She's happy. There's no problem. She becomes pregnant. And then, would you at this point, completely shake her life by stopping her metformin and starting on insulin, or would you just continue metformin? What's your view in clinical practice? What do you generally do?
So I have mixed views when it comes to metformin at a personal
Okay.
level. So I am actually very, very comfortable with insulin. And
Right.
whenever it comes to pregnancy, probably my first and only option would be metformin, insulin. There are some exceptions. For instance, sir, if the patient has been diagnosed with GDM at a later stage of pregnancy
Right.
and the sugars are not that high, and
Mm.
the patient is not willing for insulin, maybe I would be willing to start metformin, and I do have such patients.
Right.
And this is a more reasonable and where I'm comfortable. Another area which, sir, you just very rightly put up, and is something that I face very commonly, and I'm still having a few patients on that, is those patients who were previously very well controlled with only metformin, and now they are pregnant, they are in the first trimester. So what is to be done? So, sir, this situation is definitely a dicey one. Probably I would take decisions on an individual basis and after counseling and everything to the patient. So maybe if everything is in control, and the sugars, the past HbA1c, the records and everything, and probably the gynecologist has also told that the fetus is also having a smooth growth or whatever maybe. So for that case, maybe I would not stop metformin, and maybe I would continue. But if a patient would come for the first time and in the first trimester, metformin wouldn't be my first option even till now. But then, sir, like more and more studies are coming up, and
Right.
we're getting much more positive hints at using metformin. So maybe I might change in the future, sir. So right
Right.
now it's a mixed picture.
Right. So very rightly said. So, I think there is, when it comes to pregnancy, I think we are all very cautious. I think
Very
even though this is a very, it's a good study, I'd still say a lot of,
yes.
it would still take a little bit more convincing for a lot of people really to change their clinical practice, which is completely fair. I think, end of the day, we, believe that we do no harm, right? So that's our first priority. And maybe, maybe if the patient, we need to switch and you feel more comfortable switching to insulin, I think that's the right approach. There's nothing wrong in that approach as well. As you very clearly saw, that patients who were switched to insulin also did not have any problem, right? So it was just perfectly fine
Yes.
that,
Yes.
the metformin was discontinued and, insulin was started. Those patients were also doing perfectly okay. So I think in that sense,
Actually,
maybe,
pregnancy.
yeah, yes, please.
Yeah. So it's just that it's a sensitive issue. So
Yeah,
that
it's a
is where
sensitive
we
issue.
become a little extra cautious. Otherwise, there's no harm in immediately accepting this new study, sir. That's the
Yeah,
only issue.
very, very true. Very true. I completely agree with you. Dr. Silima, there's also this, in fact, there's a lot of chatter now about early GDM, right? So, trying to predict gestational diabetes later in pregnancy, or trying to diagnose GDM, little early than usual.
Yes.
Especially Indian patients, who there is always that school of thought that, maybe the gestational diabetes actually probably occurs early and that harm has already started before you diagnose at 24 to 28 weeks. So what is your general view on this entire area of early GDM? And patients, let's say, comes to you for hypothyroidism management or for some other reason in the
Yes.
first trimester, would you screen them with a fasting plasma glucose? What's your usual approach?
So usually, basically, what I follow is when these patients come to me, say for the first time, and they haven't ever run a test, I ask a few questions. For instance, if there was a previous pregnancy where there was a history of GDM, if the patient is an obese one who follows a sedentary lifestyle, if there was a family history of diabetes, so maybe if I get any of these hints in terms of risk factors, I would myself run a fasting or a
Yeah.
sugar panel for her. But
Right.
if I get a patient who seems to have nothing at all, then maybe I would think whether to go for it or not, depending upon the situation that day. But risk factors, any of them are there, I would prefer to run a test.
Yeah, makes sense. So, selective screening, as again, most of the guidelines really say. And this study was very interesting, Dr. Silima. So it was actually a meta-analysis. Very simply, quite simply put, fasting plasma glucose more than 92, maybe need to look at them very
Yes.
closely, right? So, does that impact your practice in a sense? If you have a patient with, let's say, fasting plasma glucose of 96, would you then follow them up more closely?
So yes, sir. So maybe I would tell the patient to be more cautious in
Yeah.
terms of their diet and at least physical activity, because if we kind of intervene earlier, then we would have a better outcome or maybe a delay. If this patient was to develop GDM earlier, maybe I would be able to push it off by another few weeks if I could intervene at an earlier point.
Right. And Dr. Silima, now we are moving to an era where more and more people are having diabetes at a younger age, and more and more women are becoming pregnant at a later time in their life, right? So it's very common now to encounter women already having diabetes becoming pregnant, right? It's very, very common in practice, right? Which probably maybe I think 20, 30 years back it was something new, but now it's a common practice. In fact, maybe in a week I'll see 2 or 3 for sure patients who were, some of them my own patients, who became pregnant, right, and who were already having diabetes. So, apart from this, the issue of metformin and insulin, which we discussed, what are the other precautions that you will take in such patients when they become pregnant?
So usually, basically, whenever I have a female patient of age, childbearing age group, and
Right, right.
when they are being treated for diabetes, so like we usually take the menstrual history in each of our visits. So I do counsel them, and I always ask them, is there any plan of pregnancy or whatever is the matter? So if there is, the sugar controls are not adequate, the HbA1c is not in control, I clearly tell them that you cannot take up pregnancy right now until and unless your HbA1c comes down to a 6.5 and your sugar levels are controlled. And I also particularly advise them for contraception till the time it is controlled. Once the sugar levels start becoming controlled with whatever the medication is, then I ask them, are you intending to take up pregnancy? In that case, what I do is generally I switch it to either a premix insulin twice a day with metformin or without metformin, depending upon the patient's choice and other issues. And then, of course, I tell them that once you become pregnant, you have to immediately come and meet me, because then the targets of sugar and management would be
Right.
different. And they should also be counseled regarding comorbidities, etc.
Yeah. So very true. So I think, anybody, so you have a young childbearing lady who is having diabetes, I think it's a very important issue that pre-planning is a must. It's in fact for most endocrine diseases that you encounter, whether it's a Graves' disease, whether the patient is having hypothyroidism, any other endocrine disorder, even prolactinomas, I have seen patients, you start them on cabergoline and after a few months they become pregnant because quite simply their reproductive axis suddenly, activates. So I think it's a challenge. So I think it's very important, again, for young endocrinologists listening to this. I think they should be aware that such patients, it's very important as clinicians to really counsel them about taking a more, cautious approach as far as planning pregnancy is concerned. And that's something which is very important, especially diabetes, because it's quite simply very, very common in clinical practice. So now let's move to another topic, again, very interesting topic. And again, this area has been in vogue for quite some time. And let me launch a little poll here again. Second. I think just give me 1 second. I will come to the poll question in a minute. So little trouble in terms of sharing the poll. So, this is a paper which was published, by Mizani et al. In BMJ, which looked at subtyping of type 2 diabetes. Now, again, a lot of you who are, interested in this space would have already known that already there's a lot of talk about subtyping diabetes. The originally started with the Scandinavian study, which looked at 6 different classes of diabetes. Then there's a study done in India as well by Dr. Mohan et al., who looked at Dr. V. Mohan, who actually looked at subtype classification of type 2 diabetes, and they looked at various categories. This is, of course, in the same light. This is another study which looked at 4 subtypes of type 2 diabetes using machine learning approach. So used a machine. In fact, the earlier studies also used a machine learning approach. They of course did not use that in title, but the study by Dr. Mohan was also K clustering, which is basically a machine learning approach. So basically, just to give you a one-line summary, the study used machine learning to identify and validate 4 subtypes of type 2 diabetes and analyze the prognostic and medication burden implications in a large, a national database. So They looked at about 4 lakh patients with type 2 diabetes, with a newly diagnosed type 2 diabetes, incident type 2 diabetes, and they've identified 4 distinct subtypes. So you had a metabolic subtype, you had an early onset subtype, you had a late onset subtype, and you had a cardiometabolic subtype. And they overall looked at the subtypes, the F1 score, whether there's a predictability there also. They looked at the prognostic validity also, the risk of mortality, hospitalization, and so on. They looked at the medication burden and some other clinical implications. So overall, the subtypes, we'll discuss the subtypes here. So there were these 4 subtypes. So you had the metabolic subtype, which was the most common. Typical age was about 62 years of age, and that was a generic type 2 with, of course, no distinct comorbidities of metabolic or medication use. So this is your usual metabolic syndrome type of patient, right? So you have, type 2 diabetes, hypertension, dyslipidemia, central adiposity, and so on and so forth. Then they had an early onset subtype, which basically had an onset of about 42 years on an average. They had more strong family history of diabetes, high prevalence of depression, high rate of smoking, heavy alcohol consumption, and lower 5-year mortality and hospitalization rate. Quite simply, probably because they are younger patients. But then there are other extreme of it, which is the late onset subtype, which was mainly the mean age of about 82. These are older patients with predominantly females with higher prevalence of chronic kidney disease and other comorbidities also. So they had more, CKD as well. And then lower risk of smoking or alcohol use, but they had highest mortality and hospitalization. And then you had this mid section, maybe a cardiometabolic subtype, also, similar age group as metabolic subtype, which is 62, with high prevalence of cardiovascular disease, hypertension, dyslipidemia, and very high medication burden and worse outcome in terms of the overall mortality. So these were the 4 different subtypes. Now, why I kept this article? Because it's actually a little distinct from some of the earlier subtypes also, which looked at insulin resistance and beta cell function and other things. I think this subtype really looked at more of a practical aspect of management, which is basically looking at whether they have cardiovascular risk and age of the patient and so on and so forth, right? So I think that makes it a little interesting in terms of the different subtypes that we have. Okay, and then a few things about the other key findings. So the late and cardiometabolic subtypes had the worst outcome as far as the mortality is concerned. The early onset subtype had the lowest medication prescription rates. And probably these are the patients which also early onset have also potential diabetes remission also. And they looked at the progression, and most individuals stayed in the same subtype over time, but there's some transient changes, right? So this is the overall subtype classification. We're given the details of the how they've done the methodology, etc., on the technology.com website, so you can have a look at that, right? So I'm not going to go to the details of the same, right? So this is the cluster classification method, and they used these various machine learning algorithms also to basically identify the various subtypes. Okay, so this is the overall idea, and these are the 4 subtypes which they looked at, right? Now let's come to Dr. Silima again. Dr. Silima, a lot of talk about subtyping type 2 diabetes. I think this is again a lot of people are now these days interested in a lot of studies being done about people trying to declassify type 2 diabetes, trying to label it into different categories. What are in general your views on subtype classification of diabetes?
Okay, so sir, honestly speaking, before going through these articles, I mean, of course, I have faced type 2 diabetic patients in wide variations, but I had not consciously placed them in any particular classification or subset. But yes, of course, after going through this particular article, and there are many related articles, we can understand that there are some patterns which can be grouped together and they have a different kind of a prognosis. So maybe, sir, now when I'm thinking back in the past and I'm trying to recollect the patients that I have encountered, they are definitely having some similarities and I can actually group them amongst this. And so this is for now, but maybe in future we can have a more unified sort of a classification. Correct. Where we can have some definite parameters and some definite guidelines for each subset. So as of now, that might be lacking, but this is definitely scope and space for further future work.
Yeah, very true. So I think, Dr. Silima, I think probably the challenge here is that the reason why you have this varied subtypes is because, population-wise and ethnicity-wise also, there are differences in type 2 diabetes. So Indian subset, if you can clearly see, Dr. Mohan's paper versus the Scandinavian study, yes, there's a huge difference. Yes. There had a lot of difference in terms of subtypes, because quite simply our patients, and that was mainly patients from southern part of India, even within India, yes, also, I'm very sure that
There
your
are
patients are
variations.
very different than my patients, in terms of
Yes, yes,
diabetes. So
yes,
type 2 diabetes, especially, so there is
yes.
lot of variations, lot of heterogeneity. And I think, even within populations also, there'll be a lot of changes in
There
terms of
is.
diabetes. So in your practice, just as a general, what type of, gross groups of type 2 diabetes, newly diagnosed type 2 diabetes that you see in your practice?
Okay, so like I said, so previously I had never grouped them separately as a classification. Now, since this topic is being raised, but I do get a lot of younger patients, maybe in the age of late 30s or early 40s, say somebody who's working in an MNC. And like I said, obese, doesn't have any kind of a physical activity, alcohol, smoking. So probably that would fit into the early onset kind of a category where maybe I would explain to this is where again I was talking about starting with metformin alone. So maybe this particular patient would fit into that kind of a category where there would be a possible chance of remission if he tries to accommodate the new changes in his lifestyle and gives up smoking and alcohol of sorts. Then again, sometimes we get the typical one that you've talked about, sir, the metabolic one. That is maybe in the late 50s or the 60s, just a plain Jane diabetes. There is
Mm.
nothing, there is no such comorbidities. And then we go on the usual form of treatment. Also, sir, at times we get patients who are at a very late age of life get detected with diabetes. They are having a lot of comorbidities, and at that point of time the chances of them being repeatedly admitted to hospitals,
Mm.
comorbidities, even mortality for the matter, is high. So sir, maybe I would say that also I get, sir, some double diabetes, but then that we are not keeping a part of this spectrum. We're only talking about type 2 diabetes here. So, sir, before like going through these papers, I wouldn't have separately identified them as separate entities. But after going through this, I think it's more easier to place them in a particular pattern and then go about it.
Yeah, and that's why I think, Dr. Silima, you're very right. In fact, this paper, why it really attracted me was that actually these are the type of patients that I see in my practice as well. And they're very simple and intuitive to understand. These are like early onset, late onset,
Yes,
just metabolic, cardiometabolic kind of
yes,
patients.
sir.
So
Yes,
it's a
sir.
very typical. I think maybe the ages are a little different from what we see in
Yes,
India.
yes, sir.
Maybe a
Yes, sir.
decade earlier. We see this same patients
Earlier,
decade earlier.
absolutely, sir. Absolutely, sir. A
So
decade
we
earlier, I
all,
think I would
yeah, so this
completely agree.
average of 60, maybe it's average of 50 in our patients. But I think apart from
Yes,
that, I think it's
yes,
very
sir.
similar. And
It's,
do you,
it's very similar.
very similar. So do you think, Dr. Silima, if we do this, and maybe do it more efficiently, do it better, maybe do it as a universal consensus, would that help in the era of precision medicine now? Because, there's so many
Yes,
anti-diabetic drugs, there's so
yes,
many of
yes,
them,
sir.
new ones emerging all the time, the old ones being used in new ways. Does that really kind of, this set typing really help in precision medicine?
So we have seen that each of these groups have a different prognosis. So that way, sir, coming to individualized therapy or precision medicine definitely has a big scope because, sir, for instance, if I would rub in an example, like for the first patient that I was talking about, the young, early onset, the patient. So for them, the treatment would predominantly be focusing on diet, lifestyle, and counseling. Whereas if a patient is coming with the late onset, that is with a bad prognosis one or something where there are repeated chances of hospitalization, we would be planning the treatment accordingly, counseling the patient accordingly. So we would be more careful about that patient. So I think depending upon patient to patient, if we can get this sort of a division or a classification, it would eventually help us
Yeah,
guide in
very true.
terms of individualizing therapy.
Very true. So I think the poll question, we raised the same question as poll, do you think the time has come to subtype type 2 diabetes? And majority are in favor that, probably it's something that
Yes,
should be looked at. I think there's definitely a lot of curiosity in this field, and I
yes.
think something which we definitely the need of the hour as far as, our practice is concerned. Let's then look at let me launch this next poll question. I think a very interesting and practical poll question, and this is, in line with what we're going to discuss in the next subset of discussion. So we have this based on current evidence as far as insulin stability is concerned. Uh, Okay, so let's say you're consulting a rural clinic in a region where there's unreliable electricity, right? So if you're in a rural practice, they currently advise all patients to obtain new insulin vials monthly due to concerns about temperature stability. So the clinic regularly experiences ambient temperature of about 28 to 30 degrees. So the poll question is, based on the current evidence regarding thermal stability of insulin, what is the most appropriate storage recommendation for opened insulin vials in this setting? So would you maintain currently monthly replacement protocol as temperature stability cannot be guaranteed? Would you extend safe usage to 4 to 6 weeks at room temperature based on updated manufacturer recommendations? Would you allow storage for up to 2 months without refrigeration based on extended stability studies, or would you recommend clay pot or cooling devices that require weekly potency testing? I think it's a more of an administrative question, but I think it's an interesting question nonetheless. So while you answer, let's look at some of the data and evidence regarding the thermal stability of insulin. I think you need to pay attention here because it's a very important topic for practical use also. So let's look at what is the current recommendation and how this recommendation has changed. So currently, unopened vials can be stored up to 25 degrees for maximum of 6 months and up to 37 degrees centigrade for maximum of 2 months without significant loss of patency. This is actually based on some of the current updated manufacturer recommendations. And what they're saying is that oscillating temperature between 25 to 37 degrees up to 3 months do not affect the activity of short-acting, intermediate, and mixed insulins. And again, there are field studies also being done at University of Geneva, which showed that insulin can be stored safely without refrigeration up to 4 weeks. So there is now emerging data that even at room temperature, technically, of course, room temperature cannot be Indian room temperature; it's more of Geneva room temperature. But having said that, generally insulin does remain okay. And some studies have shown that unrefrigerated insulin remains stable for up to 2 months or more. So currently, if you see manufacturer recommendations, Novo Nordisk with an updated revised guideline for short-acting and intermediate insulin says that insulins can be stored at room temperature up to 30 degrees Celsius without refrigeration for 4 weeks before opening. Biocon and Eli Lilly again talk about minimum loss of patency after 6 months at 25 degrees Celsius, and Eli Lilly says that 25 days at below 25 degrees Celsius, 12 days at 30 degrees Celsius. So that's what generally say. And as far as unopened insulin, should be stored refrigerated. Once opened, the vials can be kept at room temperature for about 4 to 6 weeks. So I think this is broadly the recommendation that once you open, you can store without refrigeration for about 4 to 6 weeks. That's the idea, but at a temperature of about 25 to 30 degrees, which is in India not that common. But that's again what the general recommendation is as far as the manufacturer is concerned, right? So these are all manufacturer recommendations, for that. But then, of course, the point here I'm trying to make is that there's a very recent study published in Diabetes Care, which is a very interesting study. They looked at insulin that was stored under steady 4 degrees Celsius room temperature, 42 degrees Celsius room temperature, and cycling between 4 to 42 degrees for 1 year. So they actually took insulin, stored them at 4, stored them at 42, and stored them at changing temperature. And what they found was that they looked at glargine and huminsulin R, and both glargine and huminsulin R maintained their stability for at least 1 year when stored at 4 degrees or under 4 degrees with cycling condition. And at room temperature, both insulin remained stable for up to 6 months at room temperature, but fell below the USP standards at 12 months. And as far as the high temperature is concerned, at 42 degrees Celsius, degradation occurred regardless of whether insulin was cycled or stored. So more than 42, there was definitely degradation. But overall, short-term exposure to moderate or high temperature may not necessarily lead to the insulin disposal. And long-term studies should be used to look at the overall, look at mass spectrometry and other things also. So practically speaking, glargine and huminsulin R are highly resilient to real-world room temperature changes, maintaining potency for up to 6 months of room temperature, while cold storage remains essential. Of course, this is something which is a little bit reassuring in terms of the overall, the stability of insulin. Now, let me then also go to another study which was published 1 year back. So it is technically 2023, but it is in the same light. So I'm discussing this here, and also very importantly, it's an Indian study done by an Indian author in India, right? So this is Dr. Sanket Panse, who actually looked at looking at the potency of insulin in various conditions, and what they looked at clay pot for maintaining the insulin stability. So they found that human insulin retained 95% potency up to 2 months, but declined slightly by 4 months. And analog insulin maintained 95% potency for up to 4 months. And there are subtle structural changes in insulin over time, which was seen with nuclear medicine, NMR spectroscopy also. And insulin generally is temperature sensitive with potency reduced at temperatures about 25 degrees, posing some challenges especially in regions with lack refrigeration. And they looked at various 6 different preparations, and they found that clay pot storage reduced the temperature by about 2.6 degrees compared to the open box, And hence, they found that that is where the stability actually remained better. So what they're saying is that, insulin can remain potent for about 2 to 4 months without refrigeration, especially when stored in clay pots, reducing the cost and improving access in resource limited settings. And clay pot storage is a viable alternative. Matka, right? Clay pot is a viable alternative for preserving insulin potency in hot climates where refrigeration may not be available. So countries like India and African countries also, this is something which will be practically useful, right? So, Dr. Silima, let me get your views on this. So there is now what I believe changing, talks about changing the insulin storage recommendations, and we're kind of easing into these areas, right? So, what is generally your advice to patients in terms of insulin storage, Dr. Silima?
Yeah, rightly highlighted the importance of storage. It's not just the insulin technique that should be given importance to, because if insulin is degraded at extremes of temperature, the potency is lost. So there's no point. So usually, sir, what I tell my patient is that if, like you mentioned, the exact temperature ranges, so obviously that if we explain to the patient, it's difficult for them. So we just have to tell them where to keep, how to keep. So I tell them that anything which has not yet been opened, they can keep it at the wall of the refrigerator, that is the door of the refrigerator at the shelf. But to ensure that they, not even by mistake, it should enter the freezing compartment, because there's a mistake which these patients commonly do the moment we use the word.
I think Dr. Silima got disconnected, maybe network issues. So, we asked this as a poll question, and 58%, it was a very complicated poll question in a sense. So 58% of you have said that, extended safe use at 4 to 6 weeks at room temperature 25 to 30 degrees based on updated manufacturer recommendation is what you will consider doing. Let me share these results. So the idea really is that, I agree, right? So basically, you can actually, the point is that if you're keeping it 25 to 30 degrees, it is probably okay to store it at room temperature. But of course, in India, more than, and this study, the first study which I showed you, up to 42 degrees, it is probably okay. More than 42 degrees, you are then losing potency. So I think that is something you have to be aware. So a lot of the times, if your patient does store the insulin at room temperature without missing it, it's not a problem. But generally, again, as routine practice, you tell them to store it in the refrigerator where you keep the water bottles. But sometimes, if the patient misses it out, and if it's in a climate like current climate in winter, most parts of India, it is probably okay to keep it there. And again, where you don't have electricity, maybe clay pots would be useful. And the final study of today, which we'll discuss, is so let me run the last poll question for today. And that is basically, let's again look at a clinical scenario. So you have a patient with 58-year-old patient with 10-year history of type 2 diabetes, presents for follow-up, and his current blood pressure is 142/88 on amlodipine 5 milligram. He has no history of cardiovascular disease. His kidney function is normal. He tolerates the current medication well. What would be the most appropriate systolic blood pressure target for this patient? So would you like to keep it less than 140? Would you like to keep it less than 130? Would you like to keep it less than 120? Or would you like to keep it less than 150? Right. So that's the poll question. And let's look at some evidence on this regard. So this is a study which is called the BP ROD study. Again, got a lot of attention across the country, and again, got a lot of attention in international press. Also, there's actually a study done from China. What is very interesting is that China is doing a lot of interesting studies. So I think Indians need to buck up. We need to really pull our pants and do good number of studies, right? Look at this China study. It is published in New England Journal of Medicine. It's probably a proud moment for them. It's a great study. So the study investigates whether intensive blood pressure control, that is less than 120, is more effective than standard control, that is less than 140 systolic pressure, in reducing cardiovascular events in type 2 diabetes. It was a randomized control trial at about 145 sites in China, including 12,000 participants with type 2 diabetes. So they divided into an intensive treatment arm with BP less than 120 and a relaxed arm with BP less than 140, and the composite outcome was non-fatal stroke, non-fatal MI, and risk of hospitalization for heart failure or death from cardiovascular causes. And they looked at overall, what they found was that intensive treatment group showed a significant reduction of primary outcome with a hazards ratio of 0.79 compared to standard treatment group. So definitely more intensive control had a better outcome. in terms of cardiovascular risk reduction. So basically, the practical take-home message here is that patients with type 2 diabetes targeting a systolic blood pressure less than 120 may lead to a significant reduction in major cardiovascular event. Again, of course, provided that the patient does not develop hypotension. So, Dr. Silima, if we can have you back, are you there?
Yes, sir. I think there was some technical glitch, so I just got locked out for a few minutes and then.
Okay, not an issue. So Dr. Silima, so we'll take your views on thermal stability. We are talking about that, but let's now, discuss a little bit about the study on blood pressure targets. And this is a study from China, which looked at, published in New England Journal of Medicine, recently published. Again got a lot of attention, where they looked at 120 versus 140 as a target, right? And what they found was that patients with blood pressure less than 120 actually had less cardiovascular outcome than those with less than 140. So, what are your views on this? And what in general, what is the blood pressure target that you'd like to keep in your patients with type 2 diabetes?
Yes. So I think this is a very pertinent area because hypertension is very commonly prevalent in patients of type 2 diabetes, and management is very crucial in order to prevent complications.
Right.
There was a systolic target of 140 versus 120, and it was shown that in both the arms, the primary outcome in terms of cardiovascular event as well as mortality was the same, but effects were more in the arm that had a stricter control. So for quite some time, 140 was the target that they asked for. But later when the other side was reassessed, they actually showed that in patients who are having some category.
I think Dr. Silima probably is facing some technical issues. We apologize for that. Live events. These are challenges we often face. But just to kind of reiterate what she was trying to say is that looking at more modern studies, more intensive treatment arm is really something which should be there. And we asked this as a poll question, and 50% of you wanted a blood pressure less than 130. But if you look at the new study from China, probably less than 120 should be the target, as long as you do not develop hypotension. And again, the choice of antihypertensive drugs would be, of course, dependent on the clinical circumstance, but generally ACE inhibitor and ARB, as we look from the renal perspective, probably should be one of the choices of the drug, right? So we'll wait for a few minutes for Dr. Silima to come back. Meanwhile, we'll take a couple of questions from the audience, which is there. Right. So Dr. Vikranti has asked that what about absorption of metformin is sustained release preparation and when ghost tablets are excreted in stool? So you're right. Some patients experience ghost tablets, especially in the stools. But when you have ghost tablets, it doesn't mean that the drug is not efficacious. Ghost tablets are generally because of the sustained release covering, which is often very resistant to GI degradation. So in that sense, the drug is definitely absorbed, but it's just that cover which kind of gets eliminated in the stool. So some patients actually do not like it. So in that situation, you can probably change the preparation. But nowadays, most manufacturers are very, make sure that you don't have ghost tablet, ghost pill type of problem. So most of the modern anti-diabetic drugs do not have this ghost pill issues. But if the patient does experience that, I think what you can say to your patient is that it is perfectly okay. It doesn't mean that the drug is not effective. The drug continues to be effective. And however, if they do have concerns, you can consider switching them to another medication if they feel that there is lack of potency of the drug because of this effect, right? So I think that's the answer to this question. Yeah. And now, if you have any more questions, we'll wait for Dr. Silima for a few minutes to join. But if she's not able to join, maybe you can ask a few questions till then. Again, so if you want a certificate for completion, it's a very simple process. You need to go to technology.com, sign up over there, and remember this is 3-part module, so you need to go through all the parts. Just don't need to read everything, but at least go through, do complete with each of them. Also the polls and the quiz questions. So you need to go through all of them. Just go through them once. it is actually going to be very useful to you also. So I would suggest that you go through that. Once you go through the entire thing, you will actually, in the end, when you reach to the last thing and completed all of them 100%, it will show you, you can now download your certificate, and this is what the certificate would look like. So it's a certificate of participation, and you can download it. Each certificate will have a unique ID as well. So, it's a unique, every certificate will be unique in that sense. And you can, share it on social media also, and you can share it. You can keep it as a storage in your files as well. So this is something which could be, somebody who is interested can be useful. Now, continuing the line of innovative, things, we are going to come up with MSLD Pro, which is a course in for mainly for again physicians, diabetologists, and endocrinologists who want to manage MSLD, which is basically the new term for NFLD. Metabolic associated liver disease. If you're interested in this topic, we are coming up with a course on this in more detail. Dr. Silima, so just last few words from you on. I'm sorry, we actually exceeded time also. Very sorry to push this a little bit more. But just one last question on your views on blood pressure management in diabetic patients. Yeah, Dr. Silima, can you hear me?
Yeah, sir, okay, am I?
Yes, you are audible.
Sir, am I audible?
Yes, the voice is breaking a little.
Am I audible? Sir, am I audible?
Yes, you are. Yeah. Can you just switch off your video so that your audio is, goes better? Yeah.
Yes, sir.
Yeah, we can clearly hear you, Dr. Silima. Yes.
Yes,
So
sir. Yes, sir. Yes, sir.
Just wanted your views on blood pressure management in diabetic patients.
Yes, sir. So, like, I'll just briefly summarize before the network even starts to pickle. So, sir, I think for any general diabetic patients who doesn't have any kind of comorbidities, we can keep a target or risk factors. We can keep a target of about 130 by 80. To patients who are having any kind of risk factors or a ACVD or a CKD for the matter, the targets can be more stringent, like 120 by 80. And for patients who do not really have anything, just a diabetic patients, we can think of 130 to 140.
Right. Okay. And what's your choice of anti-diabetic drug, anti-hypertensive drug in a diabetic patient?
This again would vary depending upon individual patients, because for the matter, if a patient is having blood pressure for the first time, type 2 diabetes, we need to take care of the cardiovascular safety. So for that, maybe a ACE inhibitor, ARB, or a thiazide for the matter can be chosen. If the patient is having proteinuria with a raised urine ACR, if there is hypertension in the background of diabetes, I would obviously first opt for a ACR or a ARB. And if the patient is type 2 diabetes, hypertension with an ACE-ARB, but the patient is having a background of ischemic heart disease or a heart failure component, once the heart failure component is taken care of, I would also wish to introduce a beta blocker.
Great, that's a great point. So I think, Dr. Silima, thank you so much for being a part of this. I think you're wonderful. And, the entire, diabetes thing, I think thank you for really adding your, valuable insights into this. Once again, dear audience, thank you for being part of this, right? This was the last part, and we are, we are very happy to really see the engagement levels which we had in all the 3 sessions. Again, we had Dr. Lakshmi Nagendra also who joined us for this session. So as an audience, we'd like to thank Dr. Lakshmi Nagendra, we'd like to thank Dr. Tejal, who was part of our obesity and metabolism part 2. And finally, Dr. Silima, who, so graciously accepted to being a part of our diabetes YEARMED, the part 3 of this. We hope to do more of these every year. So, watch out for this. We'll be generally doing this in November and December, at the close of the year end. And we are going to come up with more innovative, little CMEs like this, where we have high engagement, good quality content, very good speakers like Dr. Silima, who can really, take the audience with them. So I think that is what we are looking for. At the end of the day, great content really something which is very important in the medical education space. So I think that is what we are looking at. Again, very importantly, I'd like to thank our sponsors for today, Azadio. Azadio is basically empagliflozin with linagliptin, and they were always at the forefront of taking charge of the entire event. Also, very importantly, not a single slide from any of this entire presentation has any editorial inputs from the sponsors. It is completely free from any bias, free from any kind of intervention from the sponsors. It is completely unbiased editorial content, right? So I think that is quite remarkable. So I think big thanks to Azadio for being a part of generous part of this entire event. So once again, we end the session here, and we hope to see more of more of such sessions in future, and we hope to see all of you join us for more academic activities and endeavors in future. So thank you once again. Like I said, this will be available to you as a recording on technocrinology.com and also our Endocrinology India website, YouTube channel. So you can search them out, and we'll be sharing the updates also on our WhatsApp channel as well. So keep watching those spaces, and thank you once again for listening, and thank you again, Dr. Silima, for being a part of this. Thank you. Good night.
Yes, sir. Thank you, sir, for the invitation. It was indeed an enriching and learning experience. Thank you.
Thank you so much. Good night.